Morning. Welcome back to Open Med School. I am Dr. Andrews, Professor of Medicine, Consultant Neurologist. Today I will be discussing on normal and abnormal heart sounds. Auscultation, when correctly done and practiced, remains one of the most important and valuable methods of cardiac examination. So let us start with the first heart sound. First heart sound, as we know, is produced due to closure of the atrioventricular valves. So this is the right ventricle, this is the left ventricle, and this is the atrioventricular valve. It's a mitral, this is tricuspid. When the ventricle contracts, the pressure inside the right and left ventricle increases, and that produces closure of the, so that is the start of systole. So we'll mark the first heart sound as a single line, even though there are two parts, the tricuspid component and the mitral component, but they are so closely narrow that there is no obvious split is there. So it's narrowly split. The first heart sound can be loud whenever there is a hyperdynamic circulation, when the ventricles are contracting more forcefully. And typical example where the first heart sound is loud pathologically is mitral stenosis. The mechanism by which mitral stenosis produces loud S1 we will discuss in the later session. The loud S1 in mitral stenosis means the mitral valve is still pliable. If the mitral valve is calcified or there is an associated mitral regurgitation is there, you will not get loud S1. So this point to be remembered. A loud S1 is often sign of pliable but stenotic mitral valve. So soft S1 you get in, we have already mentioned the mitral regurgitation, because the valves are not getting approximated properly. Or whenever the contraction of the ventricle is ineffective, as in heart failure, the first heart sound will be soft. Myocarditis again. So remember these 2 points, that is the first heart sound depends upon the closure of the AV valves. The valvular component is there, ventricular component is there, and so when the ventricles are not functioning properly, the heart sound S1 will become soft. Hope this point is clear to you. Now we go to the second heart sound. Second heart sound is produced due to the closure of the aortic and pulmonary valve. So let us draw the heart again once more. So this is the ventricle. So here is the pulmonary and here is the aorta. So during systole, blood is pumped into the pulmonary and aorta. When the ventricle relaxes, what happens? The pressure inside the ventricles will come down. So the blood that has entered the aorta will try to come down, same in the pulmonary also. This will produce the closure of the pulmonic and aortic valves, and that is the end of systole. So we have already said the S1 marks the beginning of systole and the S2 is the end of systole, and just got the 2 components, the A2 and P2. And normally the systole contributes approximately 0.3 seconds and diastole approximately 0.5 seconds. Total 0.8 is the cardiac cycle. So when you are drawing, see that we are giving the space like this, that the systole should be shorter and diastole should be longer. So the abnormalities of the second heart sound are, one is a loud S2 that can occur in pulmonary hypertension. More important is the fixed split of a wide and fixed split of second heart sound. That is, normally the second heart sound is heard as single in expiration and as double in inspiration. This is the normal split. So when the split is heard both in inspiration and expiration and there is no difference, that is what is called a fixed split. It is classical finding that you get in atrial septal defect. The details and mechanism we will discuss in another session. And wide and variable split you get in right bundle branch block. Reversed or paradoxical split you get in left bundle branch block. Just at this time, you just remember this point, that is RBB produces wide and variable split. In right bundle branch block, what happens? The right ventricle gets activated late. So what happens? The right ventricular contraction goes for a little more time and the P2 component will be delayed. So normally the second heart sound you are drawing A2 and P2. So in right bundle branch block, what happens? The P2 occurs little later, but the variability is still there. That is what is called wide and flexor split. In left bundle branch block, what happens? The left ventricle gets activated delayed. So it will be contracting for some more time. So what happens? So this is the S1, this is the S2, and this again S1. What we have? This is the P2. The A2 will cross over to the, or the A2 will occur after the P2. So that is what is called the paradox. So how will you identify it? So normally during inspiration the split is heard and expiration the single sound. The reverse happens. That is in paradoxical split. Inspiration you get a single sound and in expiration you get it as a two sounds. Hope this point is clear. So paradoxical splitting is a hallmark of delayed left-sided events. So in left bundle branch block, this is what is happening. Now we go to the third heart sound. So third heart sound, what is the mechanism? So this is S1, this is A2 and P2, this again S1. So we'll draw the heart also. So this is the mitral valve, this is the tricuspid valve. So during the diastasis, that is during diastole, during rapid filling space or rapid filling of ventricle occurs, and during that phase you may get an additional sound that is called the third heart sound. So S3 occurs during diastole. So S3 is a little confusing thing because it is normal up to the age of around 30 and after that it is a abnormal finding. So S3 is a diastolic sound, it is a low pitch sound, it has to be auscultated with the belt of the stethoscope. So it is physiological in young adults and in pregnancy. In mitral regurgitation you may get an S3. Pathological in heart failure and mitral regurgitation. In mitral regurgitation what is happening? There is less amount of blood is going into the left atrium and this will be coming back during the rapid filling. So there is increased volume coming and that is leading, this increase in the filling of the ventricle that occurs leads on to S3 in mitral regurgitation. So the S3, especially left ventricular S3, is a hallmark of left ventricular failure. So S3 is one of the most useful signs of systolic dysfunction. So it is a feature of heart failure. So we have studied the third heart sound. Sometimes the additional heart sound like S3 in the presence of tachycardia will be looking like, or it appears like the cadence of a horse, and that is called the Gallop rhythm. So Gallop can occur whenever there is an additional heart sound like S3 and S4. These both sounds are there, S3 and S4 is there, and then there is a fast rate. It will appear like the cadence of a horse, and that is called a Gallop. And when both are there, it is called, or that is S3 and S4 are together with the tachycardia, is called the summation Gallop. Now we go to the fourth heart sound. So what is the mechanism of the fourth heart sound? Fourth heart sound is due to the contraction of the atrium. So when the depolarization of the atrium occurs, it produces contraction. So let us see in the cardiac cycle, where is it? So again we will draw the heart like this. So at what time the atrium is contracting? Atrium is contracting just before the ventricular systole. So it is a pre-systolic event. So this atrium is contracting and pushing around 30% of the blood into the ventricle. So here. So we will mark the S1. So this is A2 and P2. This is the S1. So where is it? It is just prior to ventricular contraction. S1 is due to the contraction of the beginning of systole. So S4 will be just prior. So here this is the S4. So remember, S4 is due to atrial contraction. The electrical event that is occurring is the P wave. And what is the visible thing? The visible thing is the A wave in the jugular venous pulsations. Hope this point is clear. So point to be remembered is that whenever the atrium is contracting into a less compliant ventricle, whenever the ventricle is hypertrophied, it is less compliant. So any condition that produces left ventricular hypertrophy will lead on to presence of a S4 or right ventricular hypertrophy. So in the typical condition where you get a S4 is left ventricular hypertrophy, pulmonary arterial hypertension. Anything that leads on to PAH can also can occur in ischemic heart disease. S4 is the sound of atrial contraction against a non-compliant ventricle. Remember this point, that is whenever the atrium has to contract more forcefully, this will produce the sound, and it is just before the ventricular systole the atrium is contracting, so it is a pre-systolic event. So now we go to the clicks. So the clicks usually occurs in systole. So that is why it is called ejection clicks. So during the ejection of blood, a clicking sound is occurring, that is usually in systole. So we will draw the S1, this is the S2, and this is S1. So ejection clicks are produced due to ejection of blood, that is why it is called ejection click. So where can you get ejection? One is in the pulmonary artery and other is to the aorta. So the abnormal aortic or pulmonic valve, the opening of this valve will produce a clicking sound, and that is called the ejection click. So hope it is clear. Ejection clicks are opening of the aortic and pulmonic valve that occurs in systole. So it is as it is occurring in ejection, due to ejection it is called ejection click. So where is the position? So this is S1, that is the beginning of systole. So it occurs just after the isovolumetric contraction. So this is the site, it is a high pitch sound. So what are the causes? It is written here. One is the bicuspid aortic valve, then the pulmonary stenosis. The mechanical valves can also produce sounds. There is another type of click called the mid-systolic click of MVP. So let us look into what is meant by the mid-systolic click. So it should not get confused with the ejection click. Ejection clicks are due to, as mentioned, it occurs due to ejection of blood. The non-ejection click means it is not due to ejection. So let us look into this is again the heart. In mitral valve prolapse, there is excess or redundant tissues, loose tissues in the mitral valve. So when the ventricle contracts, this valve gets approximated. But once the pressure increases, it will flop into the atrium. And this produces a click sound that is called ejection click that occurs in MVP. It is not due to ejection, so it is not ejection click, it is a non-ejection click. Sorry for the error. It is not due to ejection, so it is called a non-ejection click. So where is it? This is the S1, this is the S2. It is occurring during systole, so it is a systolic event. It is not early, so that is why it is called mid-systolic, and this can be followed by a murmur. So it's a click murmur syndrome that is characteristically seen in mitral valve prolapse. Hope this point is clear to you. Now we go to what is the opening snap. Opening snap, as the term indicates, it is due to the opening of the valve. Which valve? Opening of the mitral and tricuspid valve produces the opening snap. So in which phase opening of the mitral and tricuspid valve occurs in diastole. So they are diastolic events. Hope it is clear to you. So opening snap, it occurs in early diastole. Again we will visualize it like this is the ventricle. So the valves are opening in which phase? It is during diastole. So if the valve is abnormal, this opening will produce a sound that is called the opening snap. So if you, how will you draw it? Is the S1, this is A2 and P2, this is again the S1. So this is systole. So it is only during diastole it occurs. So it is immediately just after there is a volumetric relaxation. So this is the opening snap of, usually it occurs in mitral valve, and so it is called opening snap of the mitral valve. The interval between the opening snap and S2 is called S2-OS interval, sometimes called A2-OS interval. A2-OS interval is an important point. So shorter the A2-OS interval, tighter is the mitral stenosis. Hope it is clear. That is the A2-OS interval is short, means the patient has got a tight mitral stenosis. What is the mechanism? When the mitral stenosis is very tight, what happens? The LA pressure is, there is a pressure gradient occurring between left atrium and left ventricle in diastole. So what happens? The left atrial pressure is high, so the valve opens abruptly. So the time interval from S2 to opening of the mitral valve becomes shorter. That is why in severe mitral stenosis you get a short A2-OS interval. So this shows the summary of the findings. So you can pause the video and see it. So discussed what our points that you have mentioned is given here. So now we go to the MCQ.